Hello, I am Dr. Ahilasamy from Chennai. I am going to show a case of chronic ear discharge, right? CSOM with PSRP and PMG. That is posterior superior retraction pocket with posterior marginal perforation. This 42-year-old male has been discharging on the right ear for the past 6 to 7 years. His hearing is near normal. I am taking the case under local anesthesia. Already I have given the posterior postoral infiltration. Now I am giving the transcanal infiltration at the superior quadrant, posterior superior quadrant. You can see the bulge, and again one more infiltration at the inferior part with a solution of ropivacaine 0.5% with adrenaline. That is 20 ml of ropivacaine with 15 drops of adrenaline with IV sedation. That is with remifentanil and propofol. Alternately, I use dexmedetomidine with fentanyl. The first step is to clean the ear canal. After infiltration, remove all the debris and everything. Discharge debris. Now you can appreciate the postmarginal granulation, which is weeping for the past 6 to 7 years, and the posterior superior retraction bucket. Repeatedly wash, remove all the desquamated epithelium and everything. Now I am using my own innovation, Dr. Ahila's diathermy Rosen knife or round knife to make an incision. Always use this knife at a very low power, 10 in the or lowest part in the diathermy machine. Otherwise, there will be excessive damage to the canal skin. So now I have made an incision. One of the nightmares in endoscopic ear surgery is with single hand is bleeding while elevating the tympanomeatal flap. Then I use the Rosen knife or the same knife to elevate the tympanomeatal flap. Here I am using a Rosen knife. Sometimes I use the same Rosen diathermy, Ahilas diathermy knife itself. Hardly much bleeding or any bleeding after you use this Dr. Ahilas diathermy knife. So elevate the tympanomeatal flap gently. You can see the postoral infiltration points which I have given. Transcanal I showed in the video. I am using an adrenaline soaked cotton ball that is prepared with 1 ml of adrenaline and 1 ml of 4% lignocaine. See the quality of field under local anesthesia and local infiltration. That's the beauty of doing surgeries under local anesthesia as well as with Dr. Ahila's diathermy round knife. I am dissecting. I am going to enter the middle ear. Without tear, gently elevate the flap. You can appreciate the field quality, hardly any bleeding. Please watch these videos on a big screen, on a TV, monitor or anything. You can pair the mobile to the TV monitor and watch. Now I have entered the middle ear. Gently lifting the annulus. Now the incudoseptal joint is coming into the view. Without any tear, I am lifting the tympanomeatal flap along with the tympanic membrane. In this case, there is very minimal hearing loss and the incudoseptal joint is intact. to the to my lucky. Now I am checking the mobility of the IS joint and also seeing the round window reflex. And I am checking the malleus mobility also. You can appreciate the field quality being done under local anesthesia and since I use the diathermy knife, which is my innovation. You can appreciate the stability tendon, included stapler joint, and the mobility of the malleus included stapler joint. So these are all septal homologous septal cartilage preserved in 70% alcohol, which I have cut and I am used to augment the posterior superior quadrant where there is a retraction. I am not slicing this cartilage since already there is an retraction. So I am using the thicker size cartilage. Some more I will push it in to snugly fit and over the includostepidial joint so that the hearing will be also good. There will not be further retraction. It is firm. Now I am replacing the tympanomeatal flap. Finally, I will be using the gel foam. No masted bandage. Patients are operated in the morning, discharged in the evening as daycare procedure. It is totally scarless procedure. No external scars. Thank you for watching. See you in another beautiful video. No bandage also. Thank you. You can contact me at the following address anytime. Bye bye.